To understand chronic venous disease, we start by looking at normal blood flow. When the bileaflet valves in the great saphenous vein function correctly, blood moves steadily upward. But when these valves fail to close, blood pools and flows backward, creating the superficial truncal reflux that drives varicose veins. The established baseline for correcting this reflux is endovenous thermal ablation. Both the 2023 Society for Vascular Surgery and the 2025 SKI Clinical Practice Guidelines recommend introducing a specialized catheter directly into the vein, positioning it just below the failing valve. Because this catheter will generate intense heat, we first have to protect the surrounding tissue. We pump tumescent anesthesia into the space immediately surrounding the exterior of the vein, creating a protective layer of fluid that numbs the area and absorbs excess thermal energy. With the barrier in place, the catheter tip emits targeted energy. As the physician steadily withdraws the fiber, the controlled thermal injury causes the vein walls to shrink inward and permanently fibrose, sealing the vessel shut. Thermal ablation consistently achieves high closure rates for standard veins. However, the exact mechanisms that make it work, intense centralized heat and a dense fluid-filled protective barrier, create physical limitations when we encounter complex anatomies or patients who cannot tolerate the fluid injection. This graph compares the absorption curves of two common laser wavelengths used in ablation. The blue line represents the deeper tissue penetration of a standard 1470 nanometer laser. The orange line shows the 1940 nanometer wavelength, which has a much shallower, more intense absorption profile as it interacts with intracellular water. To control that intense energy, clinicians use a tool called four-zone dosimetry. By dividing the circular cross-section of the vein into 4 geometric quadrants, the operator can precisely standardize the energy deposition, ensuring the entire vessel wall heats evenly without scorching. But physics limits this precision as the vein grows. Once a great saphenous vein expands past 12 millimeters in diameter, the distance between the central laser fiber and the outer vein wall increases, leaving a significant empty gap that makes uniform heating difficult. Severe vessel tortuosity compounds this physical gap. A rigid, straight thermal catheter cannot bend to perfectly match the winding curves of a highly tortuous vein, meaning it loses consistent contact with the inner walls. Recent Vascular Quality Initiative data reveals the consequence of these physical gaps. In veins that are both large and tortuous, the risk of recanalization sharply increases, as reverse blood flow eventually forces its way back through the unsealed pockets left alongside the catheter. When the empty space inside a large, twisting vessel exceeds the thermodynamic reach of a central laser fiber, a single point of heat is no longer enough to guarantee long-term closure. For patients facing these physical constraints, or those with an intolerance to tumescent fluid, the standard guidelines point toward non-thermal, non-tumescent therapies. These methods achieve closure without relying on heat. One approach is mechanical chemical ablation, or MOCA. Instead of thermal energy, a rapidly spinning wire physically scores the inner endothelial wall, simultaneously dispensing a liquid chemical sclerostin to irritate and collapse the vein. Cyanoacrylate adhesive offers a completely different non-thermal mechanism. Rather than scoring the wall, a dispenser drops small amounts of medical-grade adhesive that instantly polymerizes upon contact with blood plasma, literally cementing the vein walls together. Long-term randomized trials, specifically the VCLOS and LLAMA studies, have tracked these non-thermal methods over multiple years. The data shows their occlusion rates directly match the long-term efficacy of standard radiofrequency ablation. Selecting between them often comes down to patient comfort. The MOCA randomized trial recorded distinct pain profiles for both methods, revealing that the physical scraping of MOCA generally results in different postoperative discomfort compared to the chemical bonding of cyanoacrylate. Consider this specific clinical scenario based on the data we've reviewed. A patient presents with a great saphenous vein measuring 14 millimeters in diameter, with severe tortuosity and an inability to tolerate tumescent anesthesia. In this exact edge case, applying thermal energy will likely fail due to the 12 millimeter physical limit. Successfully closing this vessel requires switching to mechanical scoring or chemical adhesion. This 2x2 matrix allows us to evaluate all available venous ablation modalities systematically. The x-axis measures cost-effectiveness, while the y-axis charts the anatomical complexity of the target vein. We start by plotting endovenous laser ablation and radiofrequency ablation. These populate the quadrant representing high clinical effectiveness for straight veins, but they rank lower on comfort and higher on procedural complexity because they require tumescent anesthesia. Mechanical ablation sits in a different space. MoCA populates the moderate anatomical complexity quadrant, offering high patient comfort and precision without the need for tumescent fluid injections. Cyanoacrylate occupies the high anatomical complexity quadrant. It handles the large, tortuous veins and offers superior patient comfort, though it carries a higher immediate health economic cost for the specialized adhesive. Current global guidelines rely on extensive network meta-analyses to build these specific recommendation pathways. They weigh the hard healthcare costs of the equipment against the required patient tolerance and the specific physical dimensions of the vein. There is no single perfect tool for superficial venous incompetence. Clinical mastery is achieved by precisely matching the specific physical mechanism of your therapy to the exact anatomical constraints of your patient.